the ABC process. Because when we talk about the ABC process, you have your activating events. So what happened? What was the experience? What was the event? And then their belief system, because their belief system filters the perception of whatever the event was. That can be colored by memory. It can be colored by so many different things. And then, of course, the consequences. So, what do I do on a daily basis? My behaviors are linked to my beliefs and my memories and my feelings. And so when I have a patient that is engaging in step 3, the negative consequences, they're sabotaging themselves, it's really helpful for me as a clinician to back up and go, okay, what is their belief system? What is it that I might be missing? Because obviously I may very well be talking to them in a language that they don't necessarily understand. Meaning that, if I have a patient that continuously relapses on alcohol, I might be thinking, what are you doing? You need to do something different. You know the steps, go to a meeting, call your sponsor, these things. Why aren't you using them? And of course, if I go back to the patient's perspective, that patient may be feeling that they don't deserve to be sober, or that it's too scary to be sober. It has very little to do with going to a meeting, calling their sponsor. It's all that underlying belief stuff. So really, for me as a clinician, it really helps me when I have a patient that is in that relapse or sabotage mode. It really helps me to take a step back and look at where are they and what is their perception. Go ahead and hit the next one. So when our beliefs are irrational, our thought patterns are irrational, and our behavior results in those negative consequences. And even though I said unexpected negative consequences, sometimes they're not unexpected. Sometimes, what is the definition of insanity? Doing the same thing over and over again, despite having a negative outcome. So for our patients, if they believe that they don't deserve recovery, or that they don't know how to do it, or if they believe that they are, a bad person and not a good person, their thought patterns are going to reflect that in some of their behaviors. So sometimes I find that with some of my patients, rather than talking about their behaviors, like you need to not do this, or you need to do this, you need to be compliant, that does me no good, because the language I'm speaking doesn't match their beliefs about themselves. So I have to look at that perspective. Go ahead and hit the next one. So it kind of looks like this, right? And this is probably a very familiar picture to people. So the observable behavior, they're relapsing. They are engaging in fraternization. They are not going to meetings. They are, whatever it is, their observable behavior. And I actually use this diagram with patients. I will have them fill it out for me. Your observable behavior is X, Y, and Z. And I'll ask them, what are you thinking inside your head? What are you telling yourself? Walk me through it. What is that? And then we can identify their specific defeating beliefs. And then, of course, their core beliefs underneath it all. And I find that, it doesn't do me very much good to talk about the relapse or the fraternization or whatever it is until I'm really good with their core beliefs. What do they truly believe about themselves? And if you hit the next slide, this is another way to look at it too. Their irrational behavior, the victim stance, isolation, anger, negative self-talk. Those beliefs are, those specific ones are, I can't trust others, everyone is out to get me, no one really likes me. And then, of course, that fundamental core belief, there is something wrong with me. And so helping patients identify that, okay, you may have made mistakes, you may have done things wrong, doesn't mean that there's something wrong with you fundamentally as a person. And so that's where the crux of when they are sabotaging, I need to get to that. And I think we've mentioned a couple times during some of our echo sessions where we've asked, is the patient afraid to discharge? Are they afraid to be out there on their own? Are they afraid to be outside the system because they don't know how to do that? They've been institutionalized. They don't know what it's like to make choices for themselves. And when they do make choices for themselves, they don't turn out well. And so if that's what, I really have to be able to address that. So I kept it short and sweet because I wanted to kind of hear from other people about what is your approach? What are some of the techniques and tasks that you've used to help people when they are struggling? So I thought I would just open it up, Dr. McMillan, to what do the people on the spokes see, and how do they cope with it?
Malcolm, sounds great. Does anybody have any thoughts on that right off the bat to get us started?
This is Ray.
Hi, Ray.
Can you hear me? Okay.
Yes, we can hear you.
I like Captain Jack Sparrow's statement also, but what I've realized is, as I'm working with folks, I don't know what it's like to be a female offender incarcerated in a prison. So a lot of times I say, okay, help me understand the world as you see it. And I really tried to do just as you were explaining and try to figure out what they're seeing, and then try to apply the skills that I know and help them move forward that way.
Yeah.
So I do a lot of redefining within my own head.
That's great. Because I find that sometimes I learn, it's not that I want to say I learn from my patients, and that's why I look forward to interacting with them. And in some ways I do. I look forward to learning, what is that like? Just like, you know, I am a skinny white chick. What is it like to grow up in the what is that like? What is it like to have your entire family drink or do drugs, or to, you know, have your, what is that like? I have no, I mean, I can assume, I can guess, I can imagine, but I really don't know what that's like. And so that's absolutely awesome, Ray, because, right, I don't know. You know, I don't know.
I learned the process is kind of playing Columbo, as I think what my supervisor called it.
Yeah. Well, when I train on motivational interviewing, I often use pictures of Columbo because, you know, as Columbo is like, well, I don't understand that, you know, and talking with your patients, I don't understand, help me understand that, you know, where it is, it's like, oh, you have, the patient is the expert. They need to teach us about what's going on inside them. Thanks, Ray.
Anybody else have comments or thoughts on what Malcolm's been talking about? I know in terms of medicine, this comes up a lot with treatment adherence. It's a huge problem, right? It's super hard to take medicines, especially hard to take medicines if you have to take them numerous times per day. It's especially hard to take medicines if they have side effects you don't like, or, you know, they make you feel tired. And we constantly ask people in psychiatry to ask you to take all of these medicines at all times. And a lot of times they don't have entirely a lot of insight at times, and the mental illness can contribute to that. So that adds a whole nother layer. And so I've learned a little bit about this, and it's a super challenging topic and can be, you know, quite interesting. But I think typically in looking at this, we have to sort of really get at what the patient thinks is going on, what their beliefs are about their illness. If they even feel like they have an illness, or what they think is explaining their set of symptoms. Because to really want to take a medicine for something on a consistent basis, you have to believe that there's something wrong, and that there has to be something wrong that we can fix with the specific treatment that's being recommended. And so I think non-compliance, I mean, you hear all the time, oh, this person's, you know, back in the ER, they've been non-compliant, they're not taking their meds, oh, what's wrong with them, you know? But it is much more complicated than that. And I know I've tried to take medicines before, antibiotics a couple times a day, and even give them to my children. And it's hard, right? It's hard to remember these things and to do what we're asking people to do on a day-to-day basis. You know, and my life compared to some people might not be that stressful. And so then imagine, you know, you're incarcerated or you're dealing with all these severe social stressors. So I think sometimes, you know, it's easy to start pointing fingers and saying, oh, you're not doing what I'm telling you to do. But there's often a lot more of a complicated story there. And I think the more you can kind of get at that curiosity that you're describing in terms of why is this happening? Why are you not doing this? What's going on? What's getting in the way? You know, it's a lot more helpful than to just be like, you know, a little bit more directive with that. So that's usually my approach, is kind of working with people sort of collaboratively and really trying to see what's going on and what might be helpful and what they feel like might be helpful. I think if people have buy-in in terms of what you're doing and feel like they're helping to direct the choices that you're recommending, a lot of times it's easier to kind of achieve adherence. So sometimes giving people choices in terms of what you're doing or recommending can be super helpful in which way their treatment's going to go. So that's my 2 cents. Anybody else have other thoughts?
This is Macy over at Alpha. I like that you shared this one. Some of the things that we see or that has been helpful for us is now it's all mandatory for them to get a PREA assessment, the ACE when they first get here, to kind of give us a background of what they've been through, whether they're forthcoming about it and not at first. But then you can see how they might skate through for a while, and then their behaviors, they start getting write-ups, not attending group, until they're getting their class 2s, and then it's a chance to look at, hey, look at the trauma that they've gone through, looking at their core beliefs, and not just addressing it, hey, why do you continue to not go to group, or why are you continuing to use in the program? So I know that's been really helpful for us. So.
Macy? Anybody else have any last thoughts or comments before we shift gears to our cases? Great. Well, thanks, Malcolm. I think it's a great topic and always one to keep in mind. So thanks for doing that. I guess let's start with our first case. I believe, Ray, are you presenting today from MWP?
Yes, I am.
Awesome. We're so glad to have you presenting.
So I'm gonna put this is our first time presenting, so be nice. But I'm gonna put a little a little twist on the end with my
nice,
question.
Okay.
So I'm going to put a little twist on the end as far as some of our questions and how to work with some of the resources or lack of while we're behind the walls here. All right.
Okay.
So to start off, we're going to be working with a 48-year-old single Caucasian female. Our chief concerns at this point, she does have a violent offender designation. She's being considered for parole in 3 years. She has a general dislike for men. She'll actually use the word hatred, but she seems to be working very well with me. And we're trying to address how that came to be. She does have a trauma history, very chronic, which we'll discuss a little bit later. She has been diagnosed with schizophrenia, but there will be a question mark as we move forward. And she definitely has a fear of success as she prepares for community because she's been down for about 20, 25 years. I'll have to see that a little bit later. All right, the history of her present illness. She does have a lot of inconsistent reporting about the hallucinations. Depending on the week, she's reported hearing voices that her father has told her to quit therapy and to harm herself. And it seems like alternating weeks, she reports experiencing no hallucinations and actually focuses on other symptoms such as anxiety, anger, and panic. Historically, the hallucinations worsen as the stressors escalate, mostly around birthdays. She just had one, of which she reports suicidal ideation, but no hallucinations. She reports being able to cope through keeping busy, such as doing laundry, cleaning, that kind of stuff. So she does have some skills for distraction. She reports maintaining good conduct and having the absence of self or other harm, so she can go in front of the board for consideration for release. Her motivations remain external to herself, such as the health of her mother and the care for her disabled sister. She says that the therapy that she does is not for her. She really has a tough time trying to get that internal motivation going. She has the ability to relate her issues in a clear and coherent manner to me, to the psychiatrist, to case managers, and really very little evidence of disordered thought pattern. Current medications include Celexa, Ativan, Seroquel, and that's on our side. The rest of them are done through medical, a lot of PRN stuff, some vitamin B12, Flonase, creams and such. Keep going. Past medications that she's tried without any success includes hydroxyzine, Lexapro, clozapine, and Minopress. Prior to 2014, that was within the last couple of years. Prior to then, she had also tried Luvox, Thorazine, Cogentin, Haldol, Desero, Luvox, Trilofan, Risperidone, and that's supposed to be Phenergan. Phenergan. All right. Past history. All right. So this is kind of key. She's reported at times having hallucinations and schizophrenia around age 12, but nothing ever was. I can't find anything until she was incarcerated in '89, where she'd been hospitalized and admitted to the state hospital for suicidal ideation. She was returned to the court custody within 3 days. Nothing really remarkable. During her 6-year stay at Women's Correctional, she received various psychotropic meds for depression, continued complaints of hallucinations, and real explosive anger. Compliance was erratic and response to medications was identified as questionable. When she got released, she did not continue medications after discharging in '96 until her incarceration in 2000. There she complained of depression, auditory hallucinations, mostly paranoid type, that the police were after her and poisoning her food, with increasing impulses to bang her head against the wall. She was initially diagnosed with major depression, and a referral was again made to MSH due to posing risk to self. She was returned to court custody after 5 days, but then was returned to the hospital on the same day for a second emergent detention for threats of self-harm, as well as harm to others. Past reports identify an individual who is completely cooperative and cognizant, able to generate plausible accounts of recall, so no real memory concerns. Reports identify there's no evidence of having a state of mind impaired by mental disease or defect. Prior to current incarceration, she spent most of her time in ADSEG, so this was her first incarceration. And since her incarceration this time, she's had clear conduct for 13 years with only one minor rule violation. She cut her own hair, and really not a management problem after that first three months. She identified her management symptoms. So as she talks about management of anger, management of depression, everything's very deliberate and purposeful towards her release, her upcoming release, so that she can care for her mother and her sister, or her brother, yeah. She's inconsistent in reporting accounts of hallucinations again. Last report identified experiencing hallucinations at 12 or 13 prior to the use of street drugs, and was a response to physical, emotional, mental, and sexual abuse by her father and grandfather. That was fairly significant and lasted for approximately 12 years. She identified difficulty coping when she found belief that her mother had knowledge, and it seemed like her mother was giving permission to the adult males for abuse. Her substance abuse history, she reported use of alcohol at 12, with a last use date on any of these was just prior to this last incarceration. She described her frequency as seldom, but she would drink upward of 18 shots in a single sitting. She does not believe there are any negative consequences as a result of the alcohol use. Marijuana started at age 16, and she kind of joked around saying it was one joint at a time. She does not believe there are any negative consequences, again, resulting from the use of marijuana. She reported abusing prescription drugs, sedative type, taking 4 times the recommended dose, no recognition of consequences, and really likes cocaine. This is her drug of choice, which she started at 16 years old. She said basically an 8-ball per month, identifying getting into fights was the only negative consequence. She generally uses alone. As a result, she experiences increases of anger, loss of control, guilt, and increased aggression and hostility. Okay. She described doing so to look for guys at the bar of whom she would know were cheating on their wives, entice them to the hotel rooms, tie them to the bed, beat them up, and then leave them for their wives to find. So she had a little track of that. She reports voices reoccur approximately 1 month prior to each incarceration, of which she self-treats with crystal. She reports in the first few days of her incarceration, she's coming down and needs to get leveled out and mentally stable. Treatment placements started in Butte. Pre-release, went out to Yellowstone County Jail on a facility transfer, went to Warm Springs as a custody transfer, ended up at Montana Women's Prison in 2000, went out to Crossroads as a facility transfer, and then came back to Women's Prison in 2002. As far as her family history, her mother and her oldest brother's daughter are the only positive contacts she has, and her only reasons for actually living and maintaining positive behavior inside the prison. The oldest brother and the father are deceased from a boating accident. She has one younger brother she continues to contact, but the relationship is not a healthy one. The relationship with her daughter is strained at best, with no relationship with her son. Third child is deceased. She's the second oldest of 5 siblings. All of her siblings are boys. Per the self-report, there is a history of schizophrenia, substance abuse, criminal conduct, and suicides within the family. She's been married and divorced 3 times, has had 3 children, identified her school years as being very disinterested in school and having a lot of peer difficulty. In the 11th grade, completing her GED a little later. Her work history includes only brief periods of entry-level employment. Prior to her latest sentencing, she only had one felony, but it was a doozer. Medical history. This is not my forte, so I'm just going to kind of throw it out there. In 2012, we got all of those big words: hypothyroid, some vitamin D deficiency, some diabetes concerns. There was a note saying do not put on Reglan because of drug interactions and prolactin levels. And we have polydipsia. In 2016, there's a left calf. God, I can't say that word either. Then we got some anemia going on. In her history, she has tubal ligation and negative stress test in 2010. Her allergies are basically penicillin, amycin, and bacitracin. And here's her lab results from her last lab in February of 2017. A lot of outer range with cholesterol, triglycerides, her LDLs, and everything else was in range. As far as the screens and tests that we've done, that was done in February of this year. I don't see the date on it. The Werner identifies medium risk. We have the K10, which says there's definitely some mental health problems. On the level 1 crosscut, those are all areas of concern. She's extreme in depression, anxiety, and stress. Her anger management is off the hook. Mild to moderate social anxiety, mild to or moderate to severe generalized anxiety. And no real difficulties with self-esteem, which I thought was interesting. The PAI showed that she's generally presenting herself in a negative light, with her symptoms actually probably being worse than they are. She does have high malingering scores, high violence potential, therapeutic potential, and suicide potential. Possible personality concerns with aggression, antisocial, and borderline. Clinical scores, high clinical scores of anxiety response, depression, mania, paranoia. And of note, the schizophrenic scores were within normal limits. Diagnosis history, she's currently diagnosed by the psychiatrist with schizophrenia and chronic PTSD. So here we go. Here's the twist that I want to throw at you guys. I've got a gal that's incarcerated for the next 3 years. How would you guys like to prepare, or how would you like to see us prepare her for entering treatment inside of the community? How can I try to get the client to meet the goals for reducing victim potential and suicide potential? And is there any consideration for diagnosis? Thank you.
Awesome. That was a great presentation. Thank you so much, Ray. Very good. I guess before we go on to me summarizing, anyone else from MWP have anything else to add? Any further comments, Lynette or else?
No, she just gave me a thumbs up and said I did a good job. So.
Okay. Excellent. That was a very good job. I'll try to quickly summarize. I'm not going to repeat the whole thing, but we have a 48-year-old female. Sounds like she's had some significant violent offenses in the past. There's been a concern for schizophrenia, it sounds like, for quite some time with long-term hallucinations. She's had suicidal ideation at times. She's also had issues, it sounds like, with some behavioral stuff, getting violent, and sounds like troubles with her contact. Those are her current medications. The main antipsychotic that she's been on recently has been Seroquel. Looks like quite a fairly extensive treatment history with several different medication trials, including clozapine in the past, which is typically just used for very severe schizophrenia that's been treatment resistant. Her past psychiatric history is notable for some hospitalizations at the Montana State Hospital, mainly due to hallucinations, explosive anger, I believe suicidal thoughts. It sounds like there's also been some concern for threats towards others as well, and violent behaviors. She does have a history of trauma. It sounds like fairly extensive abuse when she was a child. Some substance use, predominantly cocaine, it sounds like, as the drug of choice, but some other things as well. Sounds like she's been incarcerated for much of the last several years, much of her adult life, it seems. She does have a few positive contacts with her mother and brother's daughter, but it seems like some limited supports beyond that. There is a family history of schizophrenia as well as substance use and suicide in her family, so maybe some biological predisposition for that. Sounds like she does have some work history, but has been incarcerated most recently for quite some time. Medical history with hypothyroidism, maybe some other endocrine abnormalities in the past, as well as vitamin D deficiency and anemia. Her most recent labs are mainly just cholesterol, which were a bit out of the normal ranges, and hemoglobin A1C, which was normal, so she doesn't have diabetes. The testing is mentioned, and then mainly looking in terms of diagnostic clarification, it sounds like, and other ways to kind of prepare her and optimize her chances for success once she's finally out of incarceration, which sounds like will be in about 3 years. Did I summarize that correctly, Ray?
That was beautiful.
Oh, thank you. Awesome. Well, let's start with clarifying questions from the network. So maybe starting over at Passages.
Hi, this is Gina at Passages, and thanks, Ray. That was an excellent presentation. We appreciate that you did it, and it was really good, by the way. So all of us had a few questions, I think. One, we were just curious because we always are under the assumption that Passages and MWP are on the same medication formulary, but then if she's taking the lorazepam, are we on different formularies?
Ooh, that's above my pay grade.
Yes. Okay. I was just curious because we were all kind of thinking, wow, we didn't, because we know that that's not available here. And we figured that we would all be on the same formulary, but it might be different.
Yep, I do not have an answer for that one.
That works. And then we wondered what her, because we didn't see it in here, what her felony charge is.
I didn't know if I could include that, actually. But we got two. Can I include that?
I believe so. It's not really identifying information. So as long as it's something that could identify the patient, I think.
All right. So we got 3 counts of mitigated murder.
Okay.
I'm looking for the exact title,
That's
but
okay.
where it ended up being. So.
That's okay.
So this is Diane then. So that leads me to another question. Is there any chance that her charges and whatever went with that could be related to mental illness? Is that?
From what I saw with the previous reports that came from the state hospital was, and I put the quote in there that said there was. Hold on. No evidence of having a state of mind impaired by mental disease or effect. That actually came from the reports, both reports at both different times from the state hospital. I can't rule it out. That's just the information that I had.
Okay.
If we go by self-report, she reported experiencing the schizophrenia about 30 days prior to each case. And then she did go on a cocaine and alcohol binge in that 30 days. So I got a co-occurring definitely as she prepared to do the crime.
So this is Gina again. So were you guys questioning a possible personality disorder as well?
Absolutely. They didn't. The psychiatrist here hasn't put anything down yet. When I look at some of what the PAI gave us, there's definitely some antisocial and some borderline stuff going on.
Yeah, I think we would agree with that as well.
This is Diane again. Are you also questioning whether or not that schizophrenia is a true diagnosis?
I am. Again, for the onset to come on 30 days prior to and have, let's see, from 95 to a 5-year difference where she's not medicated. I don't know if anybody can give me insight if schizophrenia can go into remission for 5 years and then automatically pop back up. I've just never heard of it. So
Never heard of that either.
Not a common trajectory, I don't think, typically, but.
This is Chelsea Passages. I just have one more question. On the questions for ECHO, I'm not familiar with these acronyms here that say VPI, TPI, SUI. Can you help me with that?
yeah, on the when I do the PAI, the VPI is violence potential.
Okay.
The TPI is going to be their how it's perceived, how they perceive treatment, and then the SUI is their suicide potential.
Thank you.
Yes.
Any other questions from Passages?
I think we're good right now. Thank you.
Thanks.
All right, how about Alpha? Macy, do you have any questions?
Nothing additional. Thank you. Great case.
Okay, how about Brenda? The phones.
Yes. Just a quick question, Ray, on you identified a couple of external motivators. Is there like any hook on anything internal or any big picture type thing that that she sees as important other than those two external motivators? It seems like pretty high denial in regards to the substance use, any problems with that, but does she see even like her mental health as a problem or her criminal behavior? And what is she looking at long term? What does she think she needs?
She agrees with needing therapy of some sort, but the therapist type that she's looking for is to really help her manage the deliberate behavior component so that she doesn't do something that would ruin her ability to care for her mom and or her the sister daughter type figure, because the younger female in the house is also schizophrenic but also developmentally disabled at the same time. So she's often said prior to engaging in treatment, if her mom passes away, she was going to try to commit suicide here. Since we've worked with within the treatment realm, she said, okay, I can understand that my mom's failing health. She may die while I'm in here. So my goal is to be able to get out and care for this other gal. So really not being able to, she sits back and she says cocaine's a problem. But she won't touch that as long as she has somebody to care for. And the mental health piece, she very doesn't have a lot of ownership.
Okay, all right. Thank you for that clarification.
Yes.
Brenda. How about Marilyn?
The things that kind of jumped out to me were pretty significant abuse history. It's hard to kind of discern whether the behavioral stuff is like drug-induced psychosis stuff because of the connection with using, but this is saying that she has these voices recurring a month before each incarceration, so it's very hard to tease that out. Yeah, as far as the schizophrenia and the lapse time, I just wonder if there's some other things going on other than schizophrenia. Yeah, she seems like a great candidate for a lot of therapy and significant follow-up as far as chemical dependency, if that's her primary coping skill. So that was all that I had noticed.
So you ready to take her in 3 years?
Maybe.
We can do a regroup in 3 years and maybe reassess. Okay, thanks. Any other questions, Marilyn?
No, that's all I have at this time. Thank you.
Okay, thanks.
Mm-hmm.
How about Layla or Jamie? I'm not seeing it. Oh, looks like there's a question in chat. Okay, it says the question is, was there 3 separate violent offenses or 3 offenses that occurred at the same time? And then another question is, were neither?
Well, no, there's 2 different time frames. Three significant offenses, 2 different times.
Okay.
So we have one mitigated, her first go around, and then her second charge includes 2 mitigated murder sentences.
Okay. And then another question related to that was, were the victims related to her, or did she have a prior relationship with the victims?
First one was boyfriend, and second one was husband and daughter.
Okay.
So one of the victims is a deceased child.
Oh my goodness. Okay. Thank you.
Yeah. So did she have a relationship? Yeah. Hey, depends on how you view personality disorders.
Okay. Thank you. How about Janine or Rhonda? Do you guys have questions?
I apologize. I didn't know what information I could or could not put in here. So.
Oh no, that's great. Thank you.
This is Jen at Passages, and I noticed, like, in the history, about a month prior to incarceration, she seems to have what she calls a schizophrenic episode. Did she know she was going to be incarcerated?
Yeah, working. So I have a deal planning in the back of my head where if these things were being planned, you know, it's not a question I've just come out and asked, do you believe you'd get incarcerated for killing somebody?
Okay.
But yeah, as far as the break, like I said, she started, in her words, she started using the cocaine and alcohol, and continued to find guys at the bar. So.
Because then it indicates shortly after incarceration she ends up at the state hospital, but they don't seem to find any just cause to keep her for any length of time. It looks like they release her back to custody pretty quickly.
First time I believe was 5 days. Second time was 3 days, or vice versa. But nothing significant came out.
Okay, thank you.
This is Diane, kind of along the lines with that. The schizophrenic episode she's talking about is purely self-reported, correct? So like
Correct.
That fact, she's then saying that she had this episode leading up to it.
Yes.
No collateral information. Okay.
Thank you.
Thank
You
you. Thanks, guys. It's a challenging case. Any other questions on the network before we move to Michelle or Malcolm?
I have one. This is Macy from Alpha. With her charges, is her release plan, do you think that is something that they would even consider to let her care for a disabled child and her mother based on her crimes, if that's something?
I'm trying to meet challenges kind of one at a time. I have not approached that with the board yet. I still feel like I got a good 2.5 years before that even happens.
It's a good question, though. I think a fair concern to have with her history. Absolutely.
Yes, absolutely. That's going to be something. So I actually, in our last session or two, talked about what her thoughts with, or what it would look like in that last year to 18 months doing some reunification work with the mom and the daughter, so that we can see kind of what that looks like. Again, I'm just kind of flirting with that idea.
Thanks. Let's shift to Malcolm for questions.
You know, my questions, most of them have already been asked. I think I'm curious to hear, Dr. McMillan, what you think in terms of, like, yeah, borderline, but I guess I want to flesh out the schizophrenia, the delusions, like figure out what that is. I feel like I need to know that before I could say she's got to do this or this or this, because it seems so convoluted at the time. I guess my only question would be, you know, does she seem like she's motivated to address anything, or what is she? Does she feel like she can do something, that she can empower herself to feel better or to make better behavioral choices? I'd be curious to know about that.
She'll brag about her ability to manage, this for the last 13 years and have clear conduct. So she does have the ability to have an incident happen and then make the right choice out of it, and continue to dodge the bullet for any kind of write-up or ad seg time. So again, it's very deliberate as far as why she's doing what she's doing, according to her.
Well, and then is she more of a, flaming antisocial with some of that, schizophrenia as well? Huh. Okay. I don't really have any questions. They're all.
I'm going to say yes.
Okay.
Okay. Okay. Thanks, Malcolm. How about Michelle?
Yeah, I have a few questions. I was actually thinking the same thing about the Seroquel and the lorazepam in the formulary. I was a little bit confused about that. So I wonder, I know that there have been times where you make exceptions for certain medications, so that could be the case with her. It's really interesting, the diagnosis and hearing the history. I'm kind of getting the flavor of potentially like a mood component, maybe bipolar disorder. I'll leave that up to Dr. McMillan now. But hopefully that can guide some of our treatment. I was wondering, I'm sorry if you said this, but does she have a history of any suicide attempts, or is it more just suicidal ideation?
Just suicidal ideation.
Okay. And then, as far as you can tell with the Seroquel and the citalopram, has she reported the Seroquel being helpful at all in some of the psychotic features that she's having?
So she's very inconsistent with the psychiatrist as well as myself as far as the reporting of any of the hallucinations. So it depends on the week. If it's a good week, it's helping great. If it's a bad week, it's not helping at all.
Yeah. Okay. And then same thing with the citalopram, basically, if it's helping with her anxiety, mood, suicidal ideation, anything like that, but I'm assuming it's the same.
Well, as we're sitting here, I just got a crisis call. It flashed on. It's the same person. She's having a little anxiety fit. Change of schedule going on. So we do have a change of schedule because we started groups, and she's having a little anxiety about it. So.
Okay. Yeah, both are at max efficacious dose, so it's interesting. And then my last question is, how's her sleep?
She'll report sleeping 1 to 2 hours a night for days on end, and then eventually crash. But she never presents as sleepless. She doesn't have the dark circles, doesn't have the red eyes, no sense of fatigue, that kind of stuff. So.
All right, I think those are all my questions for now.
Thanks, Michelle. I'll just do a few and then we'll kind of shift to recommendations. So I know she's been on a lot of different treatments in the past. It looks like many different antipsychotics. Do you have any details if any of those were helpful to her? I mean, Clozaril is kind of a big gun. It's sort of used last line oftentimes if people aren't responsive to other things. Do you know if that helped with some of her psychotic symptoms?
She is. She's responding better than she has on her current regimen, according to, and I have to base this off of security and some of my nursing staff. There was a medication that she responded very well to, but they couldn't remember the name, but it was real hard for the pharmacies to get the drug in here because there had to be a lab each time it was administered. So I don't know what that was, but 1 week they weren't able to deliver it, and she went quote unquote off the deep end, and really had a crash with the anxiety.
Okay, that might have been the clozapine. That's one that we have to monitor weekly labs for. It's got some risks of blood cell issues, so it might have been that one. Hard to know. Have you ever seen or heard if she's sought care outside of the incarcerated setting? Like, has she ever gone into a community psychiatric hospital because she was struggling, or sought care anywhere else? I mean, or is it only when she's incarcerated that these things are seeming to flare up?
According according to her, she had a street pharmacist that she had on the outside, and then just do the mental health stuff when she was incarcerated.
Does that mean like someone on the street who's just giving her, I'm sorry, I'm just not sure if that lingo. Does that mean like someone on the street who she's just getting meds from, or?
Yeah, well, that's who she'd get her cocaine and marijuana from.
Okay, but never had like
And
an
cocaine
outside.
was so much more effective than anything that we can give her.
Okay. Okay, but never had like an outside psychiatrist or therapist or anything like that.
No.
And do you know who the person is in her family that has schizophrenia? You said there's a family history of schizophrenia. Do we know who that was, or?
As far as I do not, it's not within either parent. She just said there's a history, but she wasn't willing to expand on that.
Okay.
She
And do we
mentioned
know
that
if-
she understood that, so.
Okay. Do we know if she'd be open to getting any kind of collateral information from her mom, or if her mom would even be a reliable source in terms of past symptoms or reporting prior to kind of the last few years?
No, I can try to get a release signed. She still hasn't developed 100% trust with me or Lynette yet. Again, we've only been here for a couple months, so she doesn't know what our intentions are. But we're building up to that. So.
Okay. And do you know if she has any other PTSD type symptoms like nightmares or flashbacks or hypervigilance or anything like that?
She'll identify nightmares about every 6 weeks. And that goes along with the sleeplessness.
Okay. Thank you. I appreciate you answering all those. Let's shift to recommendations and starting with passages. Any thoughts or recommendations for this challenging case?
This is Gina at Passages.
We had another quick question, which would, has she done any victim impact panel, any victimology, show any remorse?
Has not done the victim impact panels. Remorse. She described. I'll just throw this out. I forgot this. She describes herself over the last 6 weeks as fine emotionally. So she's never really been. She'll claim never to have really been in touch with emotions. So she's just starting to feel. We've kind of broken through that, and with that starting to feel, we have some increases in the emotion side of the house. I don't know where I was going with that. What was the question again? Sorry.
Remorse. Remorse, if she's had any victimology.
Remorse really is none. From neither side with the guilt and shame. She kind of comes off really feeling justified in doing whatever she's done.
So that might be a good recommendation, like down the road when she is out in 3 years, to really do some work long-term in a treatment program with some of the victimology and things like that.
We were thinking that a long-term program like Elkhorn might be most appropriate for her, followed by pre-release. We were thinking that pre-release, going straight to pre-release from prison, does not sound like it would be suitable for her.
How about passages?
Possibly.
How about Elkhorn followed by passages?
If somebody blew coffee out their nose, that's all right.
We were kind of approaching this that she's probably going to come to us.
Got a couple years to prepare.
And I think, this is Chelsea at Passages, I do think considering a treatment program in between pre-release might be great. And if that's not an option, then really starting to work on some of those components that might help prepare her to deal with emotions or to start to take a look at her behaviors like DBT, seeking safety, VIP, victimology, all of those components that she would get in a program like Elkhorn. If she can't go to Elkhorn, starting to do some of those programs can really help with just like coping with emotions and preparing yourself for treatment.
Sounds really good.
Right now, we're just trying to work on identifying emotions.
Yes.
Thank you.
Thanks, guys. How about Macy?
I agree with Passages. I think it'd be good to do treatment before pre-release as kind of hopefully a way to help her transition from doing such a long time in prison. And same with the victimology and later when she gets there. So I agree with Passages.
Thanks, Macy. How about Brenda?
I think the idea of treatment first is really great, and I think that the basic work that you're doing, Ray, on just like identifying the emotions, and if she could get to the point where she at least has that to then progress into a different treatment setting would be great. I also think if there's the ability to get some collateral information from the family, from a reliable source to really see what the patterns are and the observations, maybe that could be helpful to you as well. It's a hard case.
Well, that's awesome. Thanks.
Absolutely. Thanks, Brenda. How about Marilyn? Are you still with us?
Yeah, I'm still here. I'm looking at this situation and I'm not so sure she's going to look like a good candidate for parole in 3 years, even though she'll be up for consideration. She lacks remorse. There's not much of a support system. Only mom and a niece that are the only contacts. Her other kids, the one that is strained and the other no contact because she murdered their father and sibling. Not really a lot of stuff. It was a little bit confused too. She wants to take care of this disabled sister, but she's the second oldest of 5 siblings that are all boys. So I don't know if this is maybe a step or some sister or something like that she's not, immediately related to. If they're not really down with her coming into this community, I am afraid she's going to come into a community where it was a very big news scandal thing, especially if it's a small town where there may be limited acceptance of her that could really be a struggle for her. And then if there's not much family support, if she's not able to own this with some accountability, I'm not so sure how safe she's going to look to go back out into the community. So those are the concerns I have. And I'm not sure how if somebody just does not have that remorse, how do you get her there? That kind of speaks to your concerns about personality disordered stuff. So I'm sorry, I'm not really doing very well as far as solutions go, but I'm really seeing some significant problems and concerns. So
and that's kind of what I'm banging my head on is I do have 2.5 years to really do some good work and try to get her to move that direction. Do I think it's possible? Sure.
Well, there's not a good sense of what is she seeking other than just to have some value to take care of mom and sister. But, I don't need therapy. Therapy's not for me. I don't see anything wrong with what I did. And I mean, these are pretty big deals as far as the community and the nature of her crimes go. But I don't have a sense of what is she seeking. The chief concern is just the diagnostic stuff, hates men, and fear of success in a community setting. I think she would struggle even under the best of circumstances.
So yeah, I kind of bounce between motivational interviewing and verbal judo with her. It's kind of an interesting dynamic, but.
God bless you. That's a hard case.
That's really challenging. Anyone else on the phones? Layla or Jamie Ray or Janine? Anyone else I'm missing on the network? I'm going to unmute yourself as just *6. We'll just, I guess, start with Malcom. What are your thoughts and recommendations?
I agree. I think that she needs treatment before she can go to any pre-release. And what that treatment will look like will kind of be determined on how motivated she is, how willing to surrender, I guess, to the process that she is. It doesn't sound like she is very much at this point. I'm wondering too, and after I had spoke earlier, I'm wondering, some of the folks I've had that have significant trauma, they have like some psychotic features, hallucinations or whatever. So I don't know if, she's got significant trauma, but yet I wonder if the voices or whatever, the reason they can stop and start is stress response. That would be something to look at more in depth, but nope, that's it.
Okay. Thanks, Malcom.
I'm trying to get her to identify things on that track, something around anniversary dates of some sort, or without really trying to go back and relive the trauma at this point. but yeah, trying to figure out what her response is and why it happens on certain periods. So
Yeah, I would want to look at that.
Thank you. Sounds like Rhonda says that she agrees with what everyone is saying, and it's a tough case. So thanks, Rhonda. How about Michelle?
Yeah, I have a few thoughts. I think her current regimen, there's not much room to go anywhere. The quetiapine is at the max efficacious dose. Anything above that, you just start getting a lot of side effects. It's not a lot of added benefit. Same thing with the citalopram, that's the max recommended dose. I'm wondering though, with her symptoms of anger and aggression, seems like there might be a mood component. I'm wondering about if a mood stabilizer would be a good option for her. Particularly, Depakote has data to support helping with aggression and anger reduction that you could use to augment the quetiapine. I also thought about lithium for the same reason, but also if she's struggling with suicidal ideation, lithium has data. It's the only agent other than clozapine to actually reduce suicidal ideation. So potentially that could be an option. I'd be a little hesitant to increase the lorazepam at this point just because of her extensive substance use history. I'm actually pretty shocked that it's being prescribed currently. Usually it's pretty strict in the DOC system from what I've seen so far. But I wonder if something else to help her on a scheduled basis throughout the day, something like maybe propranolol or clonidine. Clonidine also has some data to help with aggression and agitation, especially in kids. And so scheduling that throughout the day may help reduce some of those symptoms as long as her blood pressure can tolerate it. Other than that, those are my thoughts I have.
thank you.
Thanks, Michelle. I just have a few things to add. I agree with what's been said. I think diagnostically it's challenging. You know, this is a complex situation. It sounds like it could be a mix of a lot of things going on. I mean, there's maybe a personality disorder component, definitely a substance abuse component. I do feel like probably a PTSD component certainly could be a complex PTSD situation. And people do sometimes get hallucinations with that, that seem like hallucinations, especially given that they started kind of in childhood and around the time that she had this trauma, especially since it sounds like the voice of her father is one of the voices, and that has to do with the trauma, it sounds like. I just wonder if maybe some of this could be PTSD related, and certainly those types of hallucinations don't respond as well to antipsychotics. So I wonder if that might be part of the reason she's tried so many things and they haven't really necessarily helped with that. That would be one thought I'm having. Another possible diagnostic thing to consider would be a mood disorder with psychosis. It seems like it's, I don't know, a little less characteristic for schizophrenia to just kind of come and go and be in remission for a period of 5 years. But certainly you could have a mood disorder if you had a mixed episode or a manic episode and had psychosis with that. You know, that might fit a little bit better with those periods of time where it just sort of crops up here and there and then has periods of longer remission. So that might be something to kind of consider as well. It definitely seems like a complex case diagnostically. And so it'll be kind of nice that you see her for such a long period of time and maybe having her do some, you know, as you get to know her, if she's open to it, you know, mood charting or kind of charting of her core symptoms and seeing how they change over time in terms of sleep and mood and psychosis, and see what seems to really impact those things. Sometimes that can help tease it out a little bit. I think as much as you can get to in terms of collateral information can also really help over the course of things, maybe talking to her mother, getting other records of places that she's been. Medication-wise, I agree with Michelle. I think Depakote or lithium would both be a good choice or reasonable choice. Depakote oftentimes can kind of decrease that impulsive aggression that people have. And it can also sometimes help the antipsychotics to work a little bit more effectively. So if she's still having quite a bit of mood variation or impulse control issues, Depakote might be helpful. So I agree with that. I do think maybe discontinuing the lorazepam might be a good idea and trying something that's not a controlled substance. The other issue with the lorazepam is it can be disinhibiting. So sometimes people who have you know, issues controlling aggression, it's almost like having a drink. You're a little more likely to do something and you can be a little disinhibited if you've had that medicine. So I don't know, I mean, just a thought, but might be one to kind of consider trying to replace with an alternative. It sounds like she is seeing a psychiatrist there, which is very good, and hopefully she'll continue kind of working with you guys to build rapport. So definitely a really challenging case. I don't have lots of great solutions either, but I think it sounds like you're doing a lot of things well and working the best with her that you can. So I'm thankful for that. And if you ever want to represent the case or give us an update, we're happy to kind of hear back how she's doing or kind of continue working on it. But it was a really challenging case and it sounds like you're doing a great job. So Thank
We'll
you.
do it 2 years from now.
Sounds good. I'll be here. All
If
right.
you want us,
Well, thank-
if you want us to do a quick presentation on where we're standing at MWP next week, I'll do that.
That would be great. Yes, thank you so much. Just even 15 minutes or so, 20 minutes, whatever you got, just in kind of updating us on what you do there and whatnot. That would be excellent. We'd really appreciate it. So thanks, Ray. So we're running a little bit late. That's my fault, but that was a challenging case. So I guess what we'll do is maybe start the next case, and if it seems like we run out of time, we can always finish it up a little bit next time. But I believe that this is a case we've already seen before. It's an update, so maybe hopefully we'll have enough time. So go ahead, Macy.
Yeah, we're just going to do a follow-up case that we presented in February. So what we were looking at was a 24-year-old Caucasian male who he violated a no contact order within 2 weeks of arriving. So he was placed on a behavior contract. He reported concerns of being able to control unstable moods, angry for many days, and when he gets mad, he tends to obsess about it, and that his crimes were an act out of rage and jealousy. He scored a 1 on his ACE and a potential victim. At this time, he wasn't taking any medications. He went to his DOC physical, and he was diagnosed with tonic-clonic seizures and recommended to use an inhaler as needed. As for his mental health, when he got here, he was prescribed Celexa 20 milligrams daily and diagnosed with cannabis dependence, methamphetamine dependence, alcohol dependence, ADHD, NOS suspected, bipolar disorder. Dr. Shackleton noted that was doubtful, and personality disorder. He does have a past mental health history, and he stopped taking the meds as he could not afford them. His substance use history, he started at the age of 10 with alcohol, marijuana 12, and then he reported he smoked methamphetamine daily for 11 years. As for a CD evaluation, he was recommended for level 2.1 intensive outpatient. As for his family history, there was some trauma there where the father had molested his sister. He does have support from his mother now that is actually improving. History, he dropped out in school in the 10th grade but did get his GED. As for other support, his girlfriend, who we now believe is his ex, who is 42 years old, that is the victim of his crime, and that's who he was violating his no contact with. So hopefully we have that done. They're not supposed to be in contact. His charges are criminal mischief and theft. Basically what his plans were at that time, we had switched it, that he needed anger management followed by his IOP recommendation. And so as for the recommendations from ECHO, they were to consider an IOP program at Mental Health Center or Rimrock, consider testing for ADHD, increase citalopram with time if tolerated and effective, consider individual counseling, consider the Rimrock Behavioral Health Program, consider clonidine for ADHD, focus issues, and anger, continue to work on coping skill, and then to consider whether or not a male counselor would be preferable, evaluate and explore history of trauma, consider low dose of risperidone to help with mood instability and irritability. So as for an update with this guy, it's been pretty awesome. We are working with Rimrock, and so Annie McCoy, who does their behavioral health program, she came over and she met with this client. And so that worked out very well. So she's got him set up in their program. Basically is continued case management for in the community for both his mental health and medical. So he is going to do that program. She's also helping. So once he completes anger management, then he'll phase into his IOP treatment over at Rimrock. He is open to having a counselor, and so he's going to be set up with a male counselor over at Rimrock. They're working on getting that set up. He's still taking his medication. I noticed he skipped a few days, but he does say that it is helping him. And he's starting to become more open with his trauma and actually being open to work on it. So we just wanted to say thank you guys for the recommendations. Everything seems to be coming together pretty well for this guy. So
Awesome. It's so great to hear. We appreciate kind of the feedback, and it's so nice to hear some of the outcomes with these cases because oftentimes we don't hear again. So, so that's awesome to hear. Are there any additional questions that you feel like you guys need answered right now, or other thoughts on kind of future directions, things you were hoping we could help continue to answer for you?
I don't think so. I think it's just nice. We've been able to coordinate services out in the community, which is one of the biggest things we've been trying to improve on here, is getting them established when they first get here instead of waiting till they get released. As we know, there's a wait time to get them established as well. So he will be, Annie is working, she set up an appointment with him at Billings Clinic as well to get his physical health taken care of and everything. So he should be able to continue care for both mental and physical health. And he has Medicaid, so that's just been, it's been awesome to see how everything's been connected and it's working for him. So
great. Does he perceive a benefit? Does he feel like he's doing better or feeling better?
Definitely. He presents as very guarded, and especially in the beginning. And now he's even kind of, he was pretty excited after Annie came over, and he even kind of let out a smile when I was talking to him. So that's pretty big for him. And he's been participating in anger management. So I think that's been good for him, and especially for him to transition into IOP. So.
Awesome. Well, I guess I'll just open it up for questions. Does anyone on the network have questions at all for Macy about this case, or other questions moving forward? I guess either questions or recommendations at this point, since it's more of just a follow-up. Okay. Well, I don't either, unless you have other questions for us. I think if things are working, let's keep doing it. And certainly if other things crop up or there's other problems along the way, we're happy to address them as it goes. But if it seems like what we're recommending and doing is working, then let's be thankful about it. And thanks for filling us in. It's always nice to hear that.
Yeah, thank you guys. We appreciate it.
Anything else, Macy, you were hoping to talk about with that case, or is that okay for today? Okay. All right. Well, thanks, folks. It was great to see you all today. I think we'll just end a few minutes early. We'll be back next week, and I think Ray's going to do our didactics. Malcolm might be gone from us next week, but we'll still be holding our clinic, so we'll see